just quickly review our agenda items, and and then we'll have welcome and introduction. So we're going to begin with some introductions of our Tobacco and Health Trust Fund board. This is a newly reconstituted group. We're very excited to be back up and running with some significant resources, and we'll get into that in our new charge in just a bit. We will also talk through, in addition to talking through the statutory charge and the budget, we'll review the history of where this board was prior to its being dissolved and going defunct for a period of time. We want to recapture that institutional knowledge. Fortunately, we also have some excellent board members who are returning for a second stint of duty that were part of the original board. So at the end of agenda item 3, I'm going to ask any of our board members who are returning board members to please feel free to share some reflections of how the board operated in the past. And if there's any color commentary that you want to add at that time, we'll pause and take that overview from our colleagues who are veterans with this work. And then we'll conclude with the next item, which is just trying to have a discussion about board operations and procedures. How often do we want to meet? What is the format that's most conducive for board members? And sort of what are some of the bodies of work that we need to take on incrementally, including potentially setting up some work groups to look at the RFP process and help inform that disbursement of funds when we get to that part. And then we'll just summarize next steps and adjourn. So with that, I will ask Melissa to conduct a roll call, and everyone could just introduce themselves briefly and any affiliation they have for the board.
Great, thank you. Welcome, everybody. I'm going to just go down our list. Do we have Deputy Commissioner Jody Terranova?
Yes, hello, thank you. Good morning, everyone. Happy to be here. As Melissa mentioned, I'm Deputy Commissioner at the Department of Public Health, and my background is as a primary care pediatrician.
Aisha Clark.
I am here. Good morning, everyone. Aisha Clark, the Executive Director of Health Equity Solutions.
Thank you. Ann Foley.
Hi, everybody. I'm Ann Foley, and my background is that I was involved in the executive branch for a few decades, dealing with health and human services policy issues, including tobacco issues, and was also involved with the board for many years, for 15 or 20 years in its previous iteration. So I'm pleased and honored to be one of Governor Lamont's appointees to the board. Thank you.
Thank you. And we have Senator Tony Harp. Oh, you're muted. There you go.
Okay. Well, good morning. I'm Tony Harp. I was a former senator representing the 10th Senatorial District. I guess when all of this passed, I remember working with Ms. Foley for many years. I was in the legislature for 21 years, and then I became the mayor of New Haven.
Thank you. Parisa Charmchi Goodwin.
Good morning, Parisa Charmchi Goodwin. I am the Executive Director of the Commission on Racial Equity and Public Health. Pleased to be appointed by Speaker Ritter and be part of this important group. Thank you.
Matthew Jasinski.
Good morning, everybody. Matt Jasinski. I'm with the law firm Motley Rice. Our founding partners, Joe Rice and Ron Motley, were among the architects of the tobacco litigation in the 1990s and the master settlement, and we continue to bring litigation against big tobacco. So happy to be part of this group.
Dr. Andrew Salner.
Good morning, everybody. Hi, I'm Andy Salner. I'm the director of the Helen and Harry Gray Cancer Center at Hartford Hospital. And I am a long-term outcomes researcher with a particular interest in tobacco issues. I've been pleased to have been one of those former members of the board, so I'm glad to be back and working with Ann and all of you on this exciting activity to see if we can help decrease the burden of tobacco on our state residents.
Thank you. Robert Boris.
Hello, everyone. Nice to meet you. I'm Robert Boris, Chairman of the Groton Economic Development Commission, and very grateful to be a part and participate in the activities here.
Tricia Orozco.
Hello, everyone. My name is Tricia Orozco. I work for Intercommunity Healthcare. I'm the Director of Intercommunity School-Based Health Centers and Practice Management, and I am proud to be serving on this board and appointed by Jason Rojas.
Michael Rell. Oh, I thought I saw him. Oh, Michael's going to be joining late. My apologies. And Representative Cindy Harrison.
Hi, good morning. I'm the representative from the 69th District, new to the board, excited to be here, appointed by Minority Leader Vinnie Candelora, and have had a long interest in of smoking from a very young age, and even when it was considered fashionable, have never taken a puff, so happy to help.
Thank you. Are there any board members whose name I did not call? Okay, thank you.
All right, thank you. It sounds good. And you could tell just from the cross section of people that we have involved in the board that this is going to be some exciting work from the legal perspective, the public health perspective, and the medical lens. We have former legislators, policymakers, and I think at the heart of all of us is a shared interest in being an advocate for evidence-based investments to try to curb the use of tobacco and nicotine. So I'm really thrilled by the appointments that all of the entities put forward. I think they took it very seriously in putting some of their best and brightest in their community and their network. So we get to benefit from this shared work together. Before we get to the second item, we have two special guests, which we're fortunate to have join us today, that I do want to recognize for some comments and to provide their vision. We have the public health chairs, both Senator Anwar and Representative Kristen McCarthy-Vahey, who were instrumental this year at working with a number of stakeholders and advocates, as well as the Department of Public Health and OPM, to really refresh our statutory authority and tighten up the focus of this board. So in that work, I wanted to just recognize them and give them an opportunity to share their hope and their vision for the newly reconstituted Tobacco and Health Trust Fund. And then we'll go into more of the nuts and bolts of the statutory charge and the history. So with that, I'll turn it to, I see Senator Anwar on my screen. So we'll start with you, Senator Anwar.
Thank you so much, Claudio. It's wonderful to see such an amazing group of individuals at this important conversation. I just wanted to recognize also my co-chair because of the work that she has done, that we have been able to do as Public Health Committee and the legislators, both in the Senate and the House. We have made this one of our priorities. We have made sure that we have appropriate amount of funds for working and moving in this direction. I'm a pulmonologist by profession and intensivist as well, so I see the impact of tobacco every single day of my life. And I say something to the patients, say that there are two things, and this is more for COPD and emphysema. I would say that there are two things that are proven to increase your lifespan, despite the fact there are billions of dollars worth of medicines and healthcare industry around taking care of individuals who smoke. One of the things that will increase individuals' lifespan is if they don't smoke or they stop smoking. That is proven to increase. And the second thing is if, God forbid, their oxygen levels drop and we provide them oxygen, that is going to allow them to be able to live longer. These are the only two things that will make you live longer. One of them saves you a lot of money, and we can collectively as a state save a lot of money as well if we take care of our next generation and prevent this from happening. And this board has a very important responsibility for the well-being of the next generation, and I'm honored to just be witness and part of the legislative process for this. Thank you, Claudio.
Thank you, Senator Anwar. And I do want to recognize your co-chair as well, Representative McCarthy Vahey, who we've had the great pleasure to work with in her new role as the House Chair. And she's been a tenacious advocate and a really good community partner in terms of trying to work on tobacco cessation. And her work with Tobacco 21 was certainly instrumental in that piece of legislation. So Representative McCarthy Vahey, if you'd like to just share some of the vision and some words of inspiration as the new board gets going.
Claudio, thank you. And thank you, Senator Anwar. So I love getting to work with Senator Anwar and Claudio and Zani at OPM. And Ann Foley, it's been an honor to work with you in the past. This group is amazing. I love listening to the introductions, and I'm incredibly just moved and inspired by what I know we will be able to do. As I often do, I'll share a little personal anecdote. I happen to be away with 24 of my family members right now, just my siblings and my mom. And we were watching home movies that my mom had digitized, and we saw one of my grandfather in the last months of his life when he was on oxygen and right before he died from emphysema. And you could see him in the film just struggling to breathe. And my children had never seen that. And I was grateful that they did. I earlier this morning actually listened in on our local prevention council meeting talking about the decreases in the perception of harm when it came to vaping and nicotine, and the increase in use that we're seeing bump back up. So some of our survey data has come out. I am thrilled that this group is getting back to work and that we were able to maintain that $12 million in funding. I know that all of you are going to do an amazing job to save people's lives. I'm so grateful for the opportunity to work together with Senator Anwar in this capacity as partners with all of you in this work, as supporting partners, so to speak. So thank you so much for the opportunity to say hello and just encourage all of you and thank you. And I look forward to our work ahead.
Excellent. And thanks for joining us from a vacation with your family. That's certainly a testament to your commitment and for the personalizing of the issue. I think all of us probably share some sort of connection to this with our family members, and it's focus of our work. So I appreciate that very much. So our next agenda item is to do a statutory review. We've alluded to some of the key components of that in our conversation so far, but if I can ask Melissa to screen share the statutory slides just so that everyone can follow along with a slide deck in front of us. Perfect. Thank you, Melissa. So as the board can see, last year through the Public Act 22-118, which was our budget and budget implementer bill, the $12 million of initial money to restart the Tobacco and Health Trust Fund was allocated as a transfer into this board. That set off a process by which we had to make sure that we were able to get reappointments to all the board. Since the board had not met for a period of over 3 years, at that time, it was critical that we reach out to all the appointing entities, inform them of the new resources and that there's open appointments. And it's conducted sort of a year-long campaign and effort, in large part to some of the advocates. I especially want to thank, Ruth and Bright, who from the different organizations really helped pound the pavement and put forward some names for a reappointment. And then this year, we were pleased that there was a piece of legislation, as we mentioned briefly, that was introduced in the Public Health Committee and has become a public act awaiting final action from the governor. And we are very hopeful that things will move forward with that. And what that bill did is it ensured that not only the $12 million of tobacco and settlement money would be deposited into our board here, but that we would get an additional $12 million in each year of fiscal year 24 and 25. Just to take stock of how much that is by way of resources in a historical context, I'll remind the board that when the board was fully functioning and dispersing resources between 2003 and 2016, the total amount of funding that the board was able to disperse at that time was a little under 30 million. By the next biennium, we will have $36 million of resources at our disposal to make those necessary investments. So significant commitment by the state and legislators, and certainly something that we all have to take with a degree of obligation and good stewards of those resources as we push through in the next 2+ years to get that tranche of money out into the community. In addition to the resources, the continuation of the $12 million of deposits in each of the years of the biennium, the bill also makes some important statutory changes and codification of existing board practices. It also takes into account, so Section 1 does require DMIS, the Commissioner of DMIS, to report to this board on the uses of the dual settlement money. Just for quick context, the state is expected to $16.2 million as part of our multi-state settlement with the Juul manufacturer. And we expect that to happen over a 6 to 10 year period. And per this legislation, those resources would be dedicated to the regional behavioral health action organizations doing prevention, education, and planning in each of the 5 DMIS regions. And they'll report to this board on the expenditure of those monies and how those monies helped advance the goals that we share. The other sections that pertain directly to our board are mostly around Section 4, which really adds a refresh of our statutory charge. It had previously been anchored around tobacco and combustibles, and a lot of the language around there was unclear whether it could explicitly cover some investments to mitigate the risk of vaping and synthetic nicotine and other vaping products. So we want it to be explicit that it's about tobacco and nicotine-related products, and this statutory refresh will allow us to explicitly make investments on the epidemic around vaping that's existing today. In addition, the legislation codifies what had been existing board practice adopted by the board to invest in CDC best practices. So the board, before it had disbanded, had made an affirmative decision that when it evaluates where it should put in resources, it would be guided by the CDC best practices in each of those buckets of recognized investment. And so this new statutory charge codifies that precedent and makes clear we're going to be guided by evidence-based practices when making RFP decisions and investments with the tobacco fund money. We had previously term limited board members to 3 years, but we add some cleanup language here, making clear that any board member whose term expires will continue to serve until an appointment made in the same way as their original appointment is actually made and achieved. We wanted to make sure that we can maintain a continuity of this board and not have lapses where if there's several board members terming out or leaving because of personal reasons, that we will then have an issue where the board could potentially be unable to act and muster a quorum to get this work moving forward. So the continuity will allow for people to stay on even after their term is expired, but also makes clear that the appointment has to happen in the same way that the original designation was made. Last, I will say that we are requiring the board to submit reports to the legislature on our activities. Last year, because we didn't have a constituted board with a functioning quorum, Melissa and I transmitted a letter of update, updating the legislature on our status with appointments, a recap of the historical charge and the investments that were made prior to the board sort of dissolving for a period, and then pointing to some next steps that we wanted to take by way of standing up the new board. This year, we hope that we'll have obviously now that we have a fully functioning board, we'll be able to make a more extensive report to the legislature. And the legislature has, in their wisdom, also required us to look at the measurable outcomes and evaluation criteria when we put our report forward. On the next slide, this goes into a little bit more depth. Melissa, if you could just move to our next slide. Yes, thank you. So this just is a little bit more detail. When we talk about what our CDC best practices, we call them out in the statute here, and it's for things like community intervention, different communication methods for disseminating information to the public, cessation intervention, surveillance and evaluation, and infrastructure administration and management. So those are the broad buckets of CDC evidence-based investment that will be the guiding posts of our work for reinvesting these funds. With that overview of our statutory charge, I'm going to turn it back to both Melissa on the OPM team and Deputy Commissioner Terranova on the public health team to walk through the history of the board and talk some about the mechanics of operationalizing the RFP to support those CDC best practices. So with that, Melissa, please take it away.
I'm going to proceed with a brief history of the board and the operating procedures. Everybody seeing my screen right now? Okay, great.
Yes.
So I apologize. For some reason, my computer is not working very well today. So the history of the board. So the board was originally established back in 1999 through Public Act 99-2. It was later codified into Section 4 of the Connecticut General Statutes. It was amended several times over the years. The board comprised of 17 members, membership of which exists today and we'll get into in a later slide, started meeting back in 2000. The legislation that was passed created a separate non-lapsing fund to accept transfers from the Tobacco Settlement Fund that can be applied and allowed the board to also apply for and accept gifts, grants, or donations from public or private sources to carry out its objectives. So it was established to get some of those tobacco settlement funds. The purpose was to create a continuing significant source of funds to support and encourage the development of programs that would reduce tobacco use through prevention, education, and cessation programs, and to support and encourage development of programs to reduce substance abuse, and also to develop and implement programs to meet the unmet physical and mental health needs in the state. That was its original purpose. And we'll talk a little bit about how that's been amended in the new legislation that Claudio just briefed on. So as Claudio noted, the board dispersed $29.2 million during its time meeting from 2003 to 2016. And it supported a variety of programs to reduce the prevalence and impact of tobacco use. It looked at focusing on tobacco counter marketing efforts, tobacco prevention initiatives, and the use of cessation programs, including the Quit Line. It also funded some other efforts such as evaluations of the programs, a lung cancer pilot, and other innovative programs and tobacco enforcement measures, as well as website development. So those were funded to a lesser extent, but funded through these dollars nonetheless. So through this $29.2 million, over 7,000 individuals received cessation services. The quit line during this time period of 2003 to 2016 helped over 67,000 Connecticut callers. And also during the same time period, over 20,000 youth were served through prevention programs. So in accordance with Public Act 15-244, the disbursements that were going to the Tobacco Fund and Health Trust Fund each year ceased, and they were paused during fiscal year 2016 through 2022. And the funds no longer were going to the Tobacco and Health Trust Fund. Public Act 17-2 removed all deposits from the Tobacco Settlement Fund to the trust fund for years 18 and 19 and transferred existing unobligated funds out of the trust fund for other purposes, resulting in the trust fund board no longer having funds that needed distribution. So due to the lack of funding, the Tobacco and Health Trust Fund Board submitted a final retrospective report in 2018 on its accomplishments, and at that time it ceased meeting. So as Claudio alluded to, Public Act 22-118 from last session reestablished the Tobacco and Health Trust Fund Board by allocating $12 million of tobacco settlement funds to be distributed into the Tobacco and Health Trust Fund each year. PA 23-92 continued to authorize deposit of $12 million in each year of the biennium, so fiscal years 24 and 25. And it also refreshed the statutory charge of the Tobacco and Health Trust Fund Board. It updated our statutory purposes for the fund disbursement, required that funding be directed to programs that use the evidence-based best practices, requires the funds board in recommending annual funds to give priority to comprehensive tobacco and nicotine control programs for specified purposes, and specified that the board vacancies, as Claudio said, be filled, and that folks can stay on past their 3 years until there is a new appointment made. So the refreshed purpose of the Tobacco and Health Trust Fund Board is really to recommend the authorization of disbursement from the trust fund. There's the renewed focus, so really focusing in on tobacco, nicotine use, and taking a better look at vaping. And then board composition continues to be what it has always been, which is 17 members, 4 appointed by the governor, 12 appointed by legislative leaders, and then 1 ex officio representative from the Office of Policy and Management. So the prior iteration of the Tobacco and Health Trust Fund Board had the foresight to contract with a university to do a deep dive into what really the history of the board, to look at the programs that it had funded since its inception, and completed a retrospective report on the work of the board that it included lessons learned and recommendations for moving forward. There was also a companion report that did a deep dive into the evaluation of the programs that were funded through the Tobacco and Health Trust Fund dollars. So the next few slides, just to level set for us, gives us a sense of where the prior iteration of the board left off and what their retrospective report and companion program overview and evaluation report suggest as lessons learned and next recommendations should additional work move forward. So in 2017, the retrospective report suggests that the group learned that cessation programs, including the quit line, have consistently reached populations with disparities in tobacco use and related disease, and that for clients with behavioral health disorders or other life stressors that have been identified in evaluations, that can actually serve as a barrier to getting long-term program engagement and can contribute to challenges with obtaining consistent evaluation data, especially with regards to assessing accurate program quit rates. So it was harder to get this to evaluate the benefits on this group of folks and get the data required to really successfully evaluate outcome. Connecticut specific ads through media campaigns using a positive tone and featuring information about how the quit line works appeared to be more effective to engage Connecticut residents in using the quit line than the national media ads. National media campaigns were successful at the time they were running, and the quit line saw more call volume, but evaluation suggested that positive tone, Connecticut specific ads were more effective. And then state and community-based prevention programs focusing on youth audiences have worked well to secure buy-in from key school and community partners. And this was noted as being a real critical implementation success, critical to implementation success. And then in looking at the lessons learned in the report that the last board did regarding a deep dive into the successes of programs, they noted very similar findings that the combination of programs funded and policy changes, including increasing the cost of tobacco products and some of the smoke-free policies that Connecticut enacted helped to reduce the rate of tobacco use. However, studies did find that there are certain subpopulations and age groups within the state that continue to show a high rate of use, even with all of the tobacco efforts. The quit rate data collection faced certain challenges. Community-based cessation program reported difficulty collecting follow-up data from participants, making it hard to define absolute quit rates. And then cost analysis data and qualitative focus group data suggested that, again, the television and online ad placements are the most cost-effective advertising strategies, and that those may be more effective in reaching desired target populations if designed properly. So recommendations that the last board left us with through their retrospective report was that the use of CDC best practice guidelines, using that as a framework for increased coordination across program areas when possible, was effective, and to increase consistency with regards to the types and focus of programs to support a coordinated approach recommended by the CDC. So really what we learned from years of experience was that we should continue funding evidence-based policies and programs, funding coordinated multi-component interventions. And again, this lesson learned is reflected in the legislation that passed this last session. And then it was also recommended that the group should integrate policy and systems level strategies into programs, including those that primarily focus on direct service provision and those that partners in tobacco prevention and control. So the goal to ensure that programs have the capacity to incorporate a greater focus on policy and systems change to further align with Connecticut programs that are already in existence and with CDC best practices. And then finally, the report goes on to recommend that the groups serve disparate populations with the evidence-based interventions, and that it bears in mind that clients from high-risk populations face multiple barriers to quitting, and that these programs may demonstrate lower overall quit rates and higher cost per participant. And that really we have to address the unique challenges of certain populations. And then to ensure that any media campaign achieves the reach, frequency, and duration needed to be effective, and that in the absence of sufficient funding, media campaigns should focus on strategic message and placement. So really making sure that our media campaigns are targeted to the populations that we want to reach. And then program and policy initiatives need to immediately address emerging products, especially e-cigarettes. So we need to be flexible in order to ensure that rates of overall tobacco use among Connecticut youth do not increase. And then I included just some additional resources that you all may find helpful as you try and orient yourselves to the board, or if you're a prior board member and you're just looking to refresh. Our Tobacco and Health Trust Fund Board of Trustees does in fact have its own webpage. I put the web link here, and I include a list of all the resources you can find up there, including after this meeting. This is where you will find the recording, minutes, and all of the meeting materials that you're seeing today. And I'm not going to go through these slides at this time, but I did include for everybody some data to just orient us all to why this work continues to be important and why the continued support of $12 million each year is important to continue to work on reducing smoking rates in Connecticut. And if you need anything, you can feel free to reach out to either Claudio or myself. I will be serving as staff to the Tobacco and Health Trust Fund Board and if you have any questions, I am always here to help you. Or of course, Claudio is available as well. Claudio, with that, I think I'll hand it back over to you.
Yes, thanks, Melissa. That's a good history of some of the board practices, and it's a good orientation. We found that 2017 retrospective incredibly helpful, coming to this work sort of from a fresh face from afar. My previous advocacy and public policy work, while in Health and Human Services, focused more on seniors, and this was less of a forward-facing issue that I worked on. So I used the retrospective as my orienting guide, and it was really well done. So I recommend it to everyone. I do want to turn to our DPH Deputy Commissioner Terranova for the discussion of some of the processes, the RFP, the CDC decisions, and then take reflections from our veteran board members who are returning back if they want to add anything to history and what we could learn from their experience. I do, just before we turn to you, Deputy Commissioner, I want to recognize that Michael Rell has joined us. He's another one of those board members who comes to us again for another stint of duty, and we are appreciative of him and his work here. And Michael, we'll pause after Deputy Commissioner Terranova gives her presentation, and I'll invite you, Anne, and Andy, who I know served previously, to give any additional insights or feedback. What do we miss? What other learnings did you have from prior iterations of the board that you want to impose on other board members here? So with that, Deputy Commissioner Terranova, take it away.
Thanks, Claudio. I just want to say the Department of Public Health is so excited that this board is being reconstituted. You know, we played an integral role, you know, the first iteration, helping to disperse the funds, and we are really excited that we're going to have the opportunity now to continue the great work that has been done. I do want to thank Barbara Walsh from the Department of Public Health, who's on this call, who spent many, many years involved with our tobacco control efforts. And she's handed the reins over to Allison Sullivan, who now runs our program. And Allison is going to walk us through the CDC framework that you've been hearing so much about that really guided the work of this board in the past, and what we're going to use as our guide going forward to help decide which is the best ways to use this money and fund resources going forward. She'll also give some specific examples so that we can get a sense of what type of work was done with these dollars, what type of evidence-based work do we want to continue going forward as we make our decisions to help disperse these funds. And she'll give a brief overview of the RFP process that went through the Department of Public Health and kind of the timeline of what that looks like so that we can get a realistic sense of how we'll be able to get these funds out into the community and doing good work. So Allison, if you'd like to start the presentation, that would be great. Thank you.
Sure. Thank you, Deputy Commissioner. My name is Allison Sullivan. I'm just making sure everybody can see the screen. I may have to shut off my video due to bandwidth issues. We'll see how it goes here, but just in case you see me disappear, that is why. I was asked to join on this first meeting to provide a little bit of history and highlight some of the CDC best practice guidance. So moving ahead. So Melissa did a great job providing a lot of history. The next 3 slides I had prepared, I was considering your Cliff Notes of that 2003 to 2018 summary report. These were some of the allocations to each one of the efforts. So the 6.6 million for tobacco counter marketing efforts, the 8.7 to the cessation program support, 7.1 million to Quitline services, and NRT, that's nicotine replacement therapy. And for us, what we have available right now, that is gum, lozenges, and patches, as well as the youth prevention programs at 3.4 million. Other efforts, as Melissa already went through, was evaluation, that wonderful retrospective report, a lung cancer pilot, which was a feasibility study, as well as some other innovative programs. And we heard about a lot of these successes, so I won't go over these again. However, I just wanted to kind of reiterate how great it was when the board adopted the CDC best practice to sort of steer funding decisions. And I just wanted to, here's a lovely picture of what that document looks like. And it's an evidence-based guide that describes programmatic structure to establish the best comprehensive tobacco control program. And Melissa did a great job explaining about those lessons learned that we found in those reports. How I can sort of add to this is when she was discussing the rate of tobacco use and how that increase in cost of tobacco products and smoke-free policies, how that has reduced the rate of tobacco. I wanted to just kind of go into a little more detail, maybe statistics. So the certain subpopulation and age groups that still show a high rate of use are adults with low income, poor mental health, disabilities, or lower educational attainment. So according to the 2021 BRFSS, the current estimate is 17.2 of Connecticut adults use tobacco. And I wanted to mention too that adults with an annual income less than 25,000 are nearly twice as likely to have used tobacco rather than adults with income over 75,000. So the difference there is about 27.8% versus 14.2%. Similar for adults with poor mental health at 30.2% versus 15.3%. So just to kind of give a little bit more detail, as well as for our high school population, older high school students who are female report poor mental health or who identify as LGBTQ are certainly populations that we are looking at. And just to provide a quick stat for that, for example, tobacco use is higher in the high school students who identify as LGBTQ+, and the rate is 17.8% versus students that identify as straight at 9.2%. So I thought I would just kind of give a little bit more information on what we're talking about when we talk about those certain subpopulations and age groups that still have that high rate of tobacco use. So there are 4 primary goals that Connecticut has adopted from the CDC best practices, and they are, as you see them here in front of you, to prevent initiation among youth and young adults, to promote quitting among adults and youth. These are the 2 programs that DPH has right now. Our Commit to Quit is adult focused, and then Vape Free CT, which is in the works, just to give you an idea of what's going on currently. Another goal is to eliminate exposure to secondhand smoke as well as aerosol, and to identify and eliminate tobacco-related disparities among population groups. Examples being, we talked about this earlier, socioeconomic status, lower educational attainment, and disability or limitations. So directly pulled right from page 84 of that 2014 document that I showed earlier, here are the recommended funding levels and allocations per category for Connecticut. We calculated for the 12 million that's currently available. So you could see some of those numbers, and you'll see them in the next slides as well. I just wanted to kind of give you an idea of what I pulled for information. For each best, I pulled a highlight and an example directly from the guidance document. So here is that number that I mentioned in that chart before for this particular category under state and community interventions. And I wanted to just provide some basic examples for statewide, and that would be coalition support for educational opportunities. And here I just wanted to call out our Connecticut Coalition, which is MATCH. Establishing a strategic plan, sponsoring trainings or conferences, or coordinating community activities for greater impact. More of a community level example that they provide in the guidance is supporting efforts to educate the public and media on the hazards of tobacco use, funding to local health departments and districts to implement tobacco-free policies, funding to community-based organizations for prevention efforts. These are all some of the examples provided in that document. And just to give the entire group an idea of what 1 year's worth of community invention funding allowed in the past, and it's a little bit maybe hard to see in the image, but in 2015, DPH contracted with 4 nonprofits. Those nonprofits were the Boys and Girls Clubs of Connecticut, and those offered prevention programming at after-school projects, as well as other things. I'm just kind of giving high-level summaries. The community mental health affiliates, where there was work completed with 7 different prevention councils. There was, you may have seen in the retrospective report. EdAdvance, which is a regional educational service center, where there were tobacco-free policy work and family events conducted, as well as Southern Connecticut State University, who implemented tobacco-free policies and coupled it with a provision of tobacco use cessation services to university students, faculty, and staff. And I assume the slides will be shared so that you can kind of look into more detail on some of these images. Another category I'd like to just go into a little bit is under the Mass Reach Health Communications. The recommended allocation is just shy of 1.4 million to prevent initiation, promote cessation, and sort of shape social norms. An example that you may have seen in the past, especially previous board members or anybody who may have seen some of these materials in past media campaigns, Behind the Haze. We have these two images down below. We also have the Commit to Quit social media that was used in the past. You'll certainly be seeing some more with work that DPH is doing now that kind of uses the same design. So because it's familiar and it's already been out there. So the former media approaches included not only these social media ads, posters, but it also included radio. It included digital gas station monitors, boosted Facebook posts, Instagram and Snapchat targeted advertising, Google text ads, YouTube videos, digital flyers. These were large media campaigns that had many different approaches. The next one I want to go into is the cessation interventions. So again, we have our amount and how it was determined in that CDC best practice guidance document. The simple quote that I pulled was tobacco use treatment is effective and highly cost effective, especially when counseling and FDA approved medications are provided without cost barriers. So that's where our Commit to Quit line comes into play. Right now, through any person in Connecticut calling into that quit line, depending on all of the questions that they answer and if they are eligible for NRT, currently there is an opportunity for a free 8-week supply. Just to give you that little added background. Again, these are examples of what the CDC means by the cessation interventions. And I just thought I'd go into a little bit of the successes, being that the quit line had registered around 7, certainly 6 high proportion of that low socioeconomic group behavioral health condition callers. And certainly we saw increased calls to the quit line as a result of these media campaigns in the past. So another category, surveillance and evaluation of all the tobacco and health trust funded projects, is certainly essential for accountability and to demonstrate effectiveness. The images that I share on this slide are 3 example evaluation reports. And again, these are just very important for your evidence-based indicators, making sure that everything that's happening that we learned from. And in the interest of time, I'm just going to keep going to our last category, which is infrastructure, administration, and management. It's no surprise here that dedicated staff is key to providing budget and contract management, accountability, and coordination. Prior to adopting best practices, these funds were used in the past for preparation of the retrospective report, and infrastructure in the form of tobacco treatment specialist trainings, or TTS, as well as conferences and trainings. So here I would just like to mention that these are the CDC recommended staffing plan for an effective tobacco control program. And that includes a program director, a policy coordinator, a communications specialist, a cessation coordinator, surveillance and evaluation staff, fiscal management staff, as well as administrative staff. So you see here where we do have people within these roles. And so you may have noticed that some staffing needs from the last slide to address the current gaps. A communications specialist and policy coordinator would be assets to the existing structure. And I thought it would be helpful just to show what the staff looks like right now in the tobacco control program. So for planning, next steps for planning of allocation of funds is preparing the request for proposal to request proposals from contractors to conduct activities to meet 4 of the 5 CDC best practice for comprehensive tobacco control programs. An RFP review committee of subject matters will score proposals and decide on the best ones to fund with these trust fund dollars. And as a result, in the past, 3-year contracts were executed and work began after this RFP process. And I thought an example timeline of benchmarks would be helpful to sort of better understand the RFP process schedule. And this is just an example, but just to start with a January 1st date for an RFP release, I wanted to just kind of provide a timeline so that you could better understand what that process entails internally. Where a letter of intent, there would be a deadline, and these are sort of just plugged in dates to give an idea when the contractor proposals would be due, when the proposer selection would occur amongst from decisions based on the scoring sheets of the review panel, the start of contractor negotiations until finally the anticipated start of contracts once the contracts are executed. And that's all I have prepared for today. However, there is my contact information in case there's any further questions. Once you're provided the slides and may have some more questions, we are happy at DPH to answer any of the questions you may have.
Excellent. Thank you, Allison. That's a lot of information we're giving folks to digest today, and we know that. So after today's meeting, we'll make sure that all these materials are posted in one central spot so that people can read them at their leisure and spend a little bit more time with some of the data and the evidence, the history, and just this process, which is very, transparent. And I appreciate DPH giving everyone a sense of expectations and when people can look for these funding opportunities. One quick question from me, Allison, if you could, to what extent can board members be helpful in that planning process? For example, around crafting the RFP, is there an interest in having board members volunteer to give ideas? And are they invited to be on scoring panels with the obvious prohibition that they can't then have an application pending before that scoring panel? But can you give a sense of committee members here where we could use help, where DPH could use the expertise and help of board members?
Sure, of course. And you said it, Claudio. Right now we have an RFP for a new quitline vendor, and we do have some board members currently on that panel to score for our new quitline. So certainly that is an avenue where we look for subject matter experts that we would be happy to have on our panel to assist us in, going through proposals, deciding which are the proposals that, would be for funding for effective, successful outcomes. So that is certainly where we would look to the board for volunteers to be a part of that panel. Again, as long as it's that there's no person that may decide to put in a proposal, then it would be a little bit more interesting. But yes, that's exactly how we would welcome the help of the board, would be within those review committees.
Excellent. Thank you. So before we wrap up agenda item number 3, I want to, agenda item 3 and 4, actually, we took those together. I want to just give an opportunity for Anne, Andy, and Michael to share any insights, any other things. Obviously, we tried our best to recreate and piece together all the good work that had happened in the period of time when the board was meeting, and to try to replicate that institutional history, but nothing beats people who were there. And maybe you could give us some insights, anything we missed or should know moving forward.
I'm Ann Foley. I just had a couple of comments, and I don't know how relevant they are. But first, I did want to thank Senator Anwar and Representative McCarthy Vahey and Claudio on behalf of the administration for reconstituting this group, and particularly for the funding that's available for us, because certainly that's one huge difference from last time around. We did we did have some funding available to us. What we found was that oftentimes when in lean budget years is that got swept. So one thing I do want to recommend to the group as we're going forward is to spend everything that we have available to us. That was one of our lessons learned, that as we tried to stretch it out and say, well, let's not spend everything we have available to us this year and spend more next year, that was not always an option that was available for us. Before my specific questions and comments, I did want to just say that I'll take responsibility for any concerns that folks have about last time around what the board did, but I want to give credit to the really outstanding board members that we had then, and some of whom are continuing, and Andy Salner and Michael Rell are here today. But I also think that Liz Keys and Suchitra from Yale are on it. I guess they weren't able to be here today, and most especially Barbara Walsh, who was a fantastic resource for the board. So I'm glad she's here. But I actually just had a couple of comments that I wanted to make based on the presentation that you all just gave. And the first thing is that I wasn't aware, I don't know how many board members were aware that Public Act 23-92 passed and made further changes to our authority. So I was just trying to look at it, and I appreciate the overview that you gave, but I always like looking specifically, at the language and what it says. So I hope that our website will link to that new statutory authority. And I would say a couple of things. One, I think it's fantastic that we are now fully focused on tobacco and nicotine efforts. It was always concerning that the statute said, tobacco and substance abuse and mental health, and we had to, because we had such limited funds, we limited to tobacco. But now we don't have to worry about that. So I think that's a really positive change that was made. But I do have a concern about the language as I just quickly looked at it and it was explained to us. And that has to do with limiting what we do to evidence-based practices. And my concern with that, frankly, is that some of the funding that we use that I think was most effective were some really innovative approaches that we tried that hadn't been tested previously. So, some of the youth programming, and in particular, what came to my mind was the Department of Corrections education and relapse prevention programming that we did, which was very innovative at the time. I don't know if other states are doing that now, but especially with what was presented to us about some certain subpopulations being really concerning to us. There may not be evidence-based practices about making a difference with certain subpopulations. So I would just ask the co-chairs of the Public Health Committee who are here and Claudio and others to think about taking that out in the future, because I feel like we're going to be limited now at looking at, what is the evidence for a particular kind of program that we want to fund. So I wanted to say that, and I did want to look a little bit further about the language in that Public Act 23-92, because I wonder if we can fund surveillance and evaluation. Maybe it's in there. I don't know. I just looked quickly. But I know that DPH mentioned that's something that's important to CDC and to DPH. So that's I guess what I wanted to say. A couple of things for DPH. Specifically, I know, and thank you, Deputy Commissioner Sullivan, for your presentation. I know you mentioned certain CDC goals had been adopted by Connecticut, and I didn't know if maybe you could just say briefly, was that us on the board last time, or was that some other process? That's one question I have for DPH, and the other is the timeline that you presented, about 10 months of releasing an RFP to the start date. I used to be there in the administration, and that maybe made a lot of sense to me at the time, but it seems really protracted to me now that I'm not sitting there anymore. So I wonder if there's anything that we can do about that. And then the final thing I'll say is, Claudio just mentioned we did items 3 and 4 on the agenda. I don't know, did we talk about board operations yet?
Not yet, Ann.
Oh, okay. So those were all of my things that I wanted to say. So thank you. And I don't know if Deputy Commissioner Sullivan, you have the answer for that about the adoption of the CDC goals. Because there were only some that were adopted, and obviously there were others that were not. So I was just wondering if you knew.
Yes, and this is Allison Sullivan again. Those are CDC goals that Connecticut adopts for our focus, and that has been in place for quite some time. Those particular goals we chose to move forward with and really focus on for our tobacco control program activities.
Okay, so DPH adopted them. Okay, thank you.
Based on CDC, yep.
All right, thank you, Ann. Thank you, Allison, for that clarification. I'll just point out that yes, indeed, we will post the statutory charge. I think it's always important. Good lesson, Ann, that I think you always taught me about: trust the words, go back to the statutory authority early on, and it's spoken as a true expert. So we will take that advice and put the statutory charge so that everyone could see it. I will confirm for you and the board at this point that Section 4 of the Public Act 2392 does specifically call out surveillance and evaluation. So it is one of the 5 called out. So that will be good. As to the point of refreshing and continuing to iterate on the charge of the board, one of the great things of having this board is now we have a built-in group of stakeholders who's committed to this work who could provide that feedback in real time. So I think that probably we'll see continuing growth, refinement, and focus of our statutory charge and refreshing it as we go through the RFP process and see what gaps exist. I'll only say that we tried to model as much as possible the opioid settlement board, which we thought was a best practice that a number of states had adopted with the opioid dollars. And they do use some slightly different standard that maybe this board wants to reflect on as we go through a year and position ourselves for potential legislative changes next year. It's evidence informed instead of evidence based. So maybe that's a standard that can open up for some more innovation, or perhaps there's other standards that states use that point to and give some priority to a recognition of a goal and some evidentiary standard, even if it's only a promising practice and doesn't have a full body of evidence behind it. But that's certainly a good conversation to keep going among the board. I'll turn to Michael and Andy, and then we'll get to the next item for agenda.
Great. Thank you, Claudio. And thank you, Deputy Commissioner Sullivan. It's almost like going down memory lane, looking at those slides and what the board had done. It is good to see Dr. Salner and others on this call. It's good to see those that were on the board in the past and so many new faces that want to be involved in this. I thought I did see Brighty Johnson on this call as well. While he may not have been a board member, he was instrumental with public comment and public participation years ago when this board had been meeting. Looking at some of the initiatives that the board had implemented back years ago, it was mentioned about the Match Coalition, and I don't know if that is still in existence or if there is a subgroup that has come out of that and they are still working, but I believe they were instrumental as well as a good resource for us and worked with the board. Anne had mentioned some of the initiatives that we were coming up with then, and it was really uncharted territory, pretty new. It's good to know that the opioid settlement is kind of a model to look at. We didn't have anything at the time to really go off of. Most concerning, as Anne would say, and I agree about the RFP. In 10 months, you never know where we are going to be in a budget situation, and we don't want to be faced with those constraints again, either through the legislature or through the governor's office, as we faced in the past. So be mindful of that there is always opportunity to find funding elsewhere, and we just want to make sure this is protected. But with the funds, we did do some really good work with the Department of Corrections and their education during incarceration and follow-ups post-release. I believe that was well instituted by the DOC at the time, and it was a good program. Ads at the time were great. Deputy Commissioner had mentioned social media at the time. I'm sure it's 1,000% greater now, the reach through social media. That may be one tool that we should be looking at. I remember radio commercials and TV ads at the time, but social media is key. Getting to those groups that don't typically, watch TV or see the news, that would be a good tool for us to look at, and all the other youth prevention. I think we worked with a number of youth service bureaus. That may have been in one of the slides that was presented as a way to get into groups otherwise not reachable. That may have been one of the final things that we had done with them, with this group at the time. But it was a great mission. Sorry that it was not funded for a while, but I'm glad. I appreciate the work of both OPM and the public health chairs to reinstitute this, and looking for better outcomes and more positive results in the future with this board.
Excellent, thanks. And Dr. Salner.
Claudia, thanks so much. Good morning and greetings to everyone, and really looking forward to working with all of you as we start this process up again. A shout out to our legislative leaders and to the governor and his team for getting the funding going to sort of start these efforts again. I think tobacco has resulted in such a heavy burden on our residents, and of course, and an unfair burden on those who can least afford it. And I think I'm hoping that our work will really continue on all of the excellent work that's been done before to help to decrease that burden. Melissa and Allison did a really great job in describing sort of where we've been and where we are perhaps right now in terms of some of the programs that DPH offers to our residents. And I do think we have laid out before us, the CDC model guidelines and evidence-based, and I guess I would say maybe evidence-based themes, if you will, because I think that's one way that we could use the evidence, but evidence-based guidelines in terms of how we might move these pressures. As you saw in the data, we've basically been allocated roughly 1/3 of the funds the CDC recommends for a state the size of Connecticut to spend on tobacco efforts. So I would call them precious funds, how we could use them to have the biggest impact on our residents. And I would just make a comment about the evaluation. We think about evaluation in two ways. One, the evaluation by each of the project awardees who will provide periodic and then ultimately final evaluations of their program with metrics as agreed upon initially when we make an award. But second of all, a formal evaluation outsider who would come in and really evaluate the programs and their efficacy, because we have a real commitment to our legislative colleagues to report back to them and say how was your investment used, and did it make an impact, and did it do the thing that we were hoping? Did it have the outcomes that we hoped it would have? And so, as much the dollars on the actual strategies itself, I think it's really important for us all to remember that the evaluation component is really a key part, and it's our only way of being able to, at the end, report back and say how our programs did. So I'm, in conclusion, I'm really looking forward to digging in and working with all of you. And thanks for the opportunity to say a few words, Claudio. Thanks.
That's great. So we have about 10 minutes left, and I do want to quickly get a pulse check for our board operations moving forward. How I'm going to propose going forward is that we just sort of take a quick check of preference in general, virtual meetings versus in person. If we are going to do in person, is Hartford, or should we rotate around the state? And general frequency. And I'll ask, any board member that wants to share an opinion or perspective to just use the raise hand function. We'll formalize this with a SurveyMonkey. I'm not under the illusion that the whole group of us will come to consensus on a date and time certain today, but I do think it's just healthy to have a discussion of if there's strong preferences. Generally speaking, I always think it's helpful for a board when newly constituted to have at least some opportunity for in-person relationship building and networking. So it may be helpful at some point, whether it be an official meeting or tagged onto a meeting or as part of a hybrid and in-person option, to have some board members coalesce in one site so that they can just have that informal discussion. But I'd like to hear from board members on preference. So we're looking for virtual or in-person or hybrid, and then the appetite for some sort of convenings, whether they be full meetings or just board retreats in person. Go ahead, Dr. Salner.
Claudia, thanks. I guess I would support the notion that having an occasional in-person meeting is great, but offering the hybrid option for people, because, I'm fortunate enough to live just a few blocks from the Capitol or work a few blocks from the Capitol and live nearby. But, other people may be at other ends of the state and their schedules are such that they may not be able to make all the meetings. So I think I would strongly argue that we offer hybrid, but we try and do at least one meeting a year in person, if possible. I think we all realize that we can get a lot of work done in a hybrid setting. Just look at today's meeting, for gosh sakes. But you're right, building relationships is better if you can do it in person. And I guess I would argue in terms of meeting frequency, that our work will ultimately determine it, because Anne, as I recall, we changed that a few times over the years. I mean, I think we started meeting quarterly, and then having ad hoc meetings as needed. I think that kind of schedule, may make the most sense. A discussion, a presentation of proposers who are submitting a proposal, and those may be ad hoc meetings either to the selection committee or to the whole board if they're a finalist. So I think it will to some degree depend upon at the moment where we are with the projects, and if all the projects sort of happen at once, there'll be a burden of meetings, and then for a while there won't be, because we'll be waiting for them to do their thing.
Thanks for that feedback. That was really well said. Senator Harp.
Thank you. I guess it really depends upon what our role is. I got a little, I'm not really clear what we do, and I really hate to say it in that way, but it appears as if the department has already done some things and allocated dollars where they think they should be, that are the dollars that are this body's dollars. And I think that, so I'm confused, long story short. If in fact people on this body are not going to be able to do certain things, perhaps because there was a conflict of interest, I'm just wondering what our role is. If it's just really advisory to the department, then certainly it could be online. We probably never have to meet, but I guess what hasn't really been clear from this meeting to me is what we do as opposed to the department.
So that's a good question. My understanding is that none of the 36 million has been spent. The board would affirmatively vote on the broad-based criteria where we're allocating the money and sort of the allocation plan, if you will. Then I understand it to be the case that DPH, pursuant to the allocation plan and dedication of resources that we all adopt and inform, they would do RFPs pursuant to such plan. And that these other programs were things that were legacy programs or that are funded through other mechanisms. It's none of the 36 that we're talking about, this tobacco trust money. If Deputy Commissioner Terranova, if you have anything to add or correct, feel free to jump in.
That's correct, Claudio. I think Senator Harp, the dollars that you were seeing was what CDC, if we followed the CDC framework based on their recommendations, that's how that 12 million would be broken out. It's not what this body is wed to, it's just showing you what the framework is recommending for each bucket, how money could be spent going forward. But the role of this board would really be to make those decisions and decide how much of that framework we're going to follow, or if we're going to diverge from it at all.
Well, I'm new and that wasn't altogether clear, so thank you for explaining that.
Absolutely. Thank you for asking.
Can I add one thing to that, Claudio?
Yes, go ahead.
But I think it's really relevant. And again, I haven't looked that closely at 23-92, but the underlying statute says that really the recommendations of this board have to be accepted by committees of the General Assembly. And Senator Mayor Harp, you remember that as well, that this board has to come up with before anything is spent, this board makes a recommendation, and then the committees of the General Assembly have to approve that, and then DPH can spend it.
Yep, good point, Ann. And that existing part of statute was unchanged by the recent Public Act. So that still remains the two-step process after the board makes its recommendations. Representative Harrison and followed by Mr. Boris.
I guess regarding how we meet, I'd like to maybe offer a little bit of perspective based on, 3 prior sessions. And to your point, Dr. Salner, the first 2 years of being totally remote was a struggle, and it was no relationships were formed. Last year, we were more in person with a hybrid. I think that we got a lot more done. I think we were able to interact with people. And I'm mindful of, myself. It takes me almost an hour still to get to Hartford. So it allowed me to make the decision of whether I could, make it to get there or not. So I'd really recommend a hybrid, but encourage people to be there as often as they can in person. So those are just my comments based on kind of some past 3 years of experience. Thank you.
Thank you. Robert?
Thank you very much. I just would like to echo the discussion about scope here. I think if it get talking about how frequently we meet is related to how involved we are in giving input on writing the RFPs themselves. So I know I, as a new member, could benefit from a clear delineation of what we're looked to, or is there a subcommittee that'll be formed to address the RFPs, or how do we participate with that? Regard to meetings, I think hybrid is great, but definitely the opportunity to meet in person. But for myself, I could use a better understanding of our role in crafting this. I have some great ideas I'd like to participate in, but I'm not sure if that's what we're looked for at this level. So that would be helpful for me.
All right, so I want to just wrap up so that we can finish on time. What I heard is some general consensus around hybrid with the option to meet in person, where if possible, we sort of encourage people to have that in-person opportunity at their convenience, but certainly try to encourage it. I also heard a discussion here where probably we want to sharpen up the expectations, duties, and level of engagement of board members. What's baseline level of engagement and the expectations of the functions that we have to fulfill statutorily, and then what are those additional things that board members can raise their hand for to get more engaged on or to dig deeper in, depending on where their passions are. So we'll take those back as follow-up. And I think we'll probably send a Survey Monkey just to get a sense of quarterly what tends to be the better times, morning, afternoon, days of the week. We'll sort of do a Survey Monkey to take inventory of that and be back in touch with the meeting schedule that we propose based on the consensus we hear from the board members. And with that, we'll also huddle with the DPH team and see if we can't craft up some specifics of duties and opportunities for board members to engage, and then just general level of expectation for the board members. Any other questions or closing comments before we adjourn today? If not, I really look forward to this work with all of you. It's going to be a lot of interesting stuff ahead, and I hope we'll have, I think we do have some of the smartest committed individuals working on this. So lots of good times ahead, and we'll see you soon. I believe officially I have to make a motion to adjourn. So I'll make the motion. Do I have a second?
Second.
Thank you. Seconded by Aisha Clark. Thank you. And all those in favor, please signal by saying aye.
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 Any opposed or abstention? Seeing none, so ordered. Have a great day, everyone, and a good weekend coming up.
Thank
Bye-bye.
you.
Thank you.
Bye, everyone.